Good evening, Thiru. Good evening.
ಹೇಗಿದ್ದಾರೆ ಸರ್? ಹಲೋ ಡಾಕ್ಟರ್ ದೀಪೇಂದ್ರ. ಸರ್, ಯು ಆರ್
Yeah.
muted, I think.
Can you see me, Thiru?
Sir. Video is clear. Your
Yeah.
audio is also very clear.
Yeah. I think we can start also.
We'll start off, sir.
You will have some additional time also.
Sir. Sir.
Correct, no?
ಹೌದು sir, definitely.
It will not make any difference.
Definitely, sir.
Correct, no?
ಹೌದು sir, ಹೌದು sir. So, organizing team ಇಂದ ಯಾರಿದ್ದಾರೆ ಅಂತ ಗೊತ್ತಾಗ್ತಿಲ್ಲ sir.
Saujanya, I think.
Saujanya, we will start the session.
Abhinava.
Yes, sir. Yes, sir.
Okay, so once the streaming starts, you just give me a quick cue.
Okay.
So we'll start the session by the keynote address by Dr. Krishna Prasad Kudlu first,
Okay.
and then we will start the surgical session.
Hi,
Sure,
Deepinder.
sir.
How are you?
Good to see you.
I still remember I had traveled all the way to Delhi. You invited me as a faculty to IQ Hospital.
Wow.
Yeah, Gurgaon. It was a fantastic conference.
Yeah, thank you. And I can see this one is also quite grand. A lot of halls running.
Yeah. Ajay, thanks to Ajay also. Tell my regards to Ajay.
Sure. I'll definitely convey. And we are looking forward to maybe have another round of similar meeting next year.
Yeah. Eager to see you all. I think when I'm in Delhi, definitely I'll make sure that I'll visit you.
Sure, sir. That will be a pleasure and honor. And
Yeah. Thank you.
to
Thank you, sir.
Hello, sir. No, sir. It's an honor to have you here. You know, we look forward to the knowledge that you are going to impart to us, and we are very interested to see those videos.
Thank you. It's not much. I think it's just one video. So, but I hope it will be a little exciting.
Yeah, definitely. You always have shown us great, exciting videos. So.
Yeah. Is it already live, Saujanya?
Yes, sir. Yes.
Yeah.
So without further ado, I think we'll start this session on surgical night in the posterior segment. But before we start the surgical video session, we would want to welcome Dr. Krishna Prasad Kudlu to give the keynote address on the resistance to resistance. So Dr. Krishna Prasad Kudlu needs no introduction, but it's my duty to give a very small one. He is director of Prasad Netralaya. He's also the chairman of Vision Committee for Karnataka, and he's also working for not just Vision in Karnataka, but also for Andhamukta Goa. And he's a man with no boundaries. So I would like to welcome Dr. Kudlu Krishna Prasad to give the keynote address. Sir, over to you.
Thank you, Tirumalesh, for a kind introduction. I think I thank Elon for the opportunity, but for this particular presentation, I thank Allergan India, who has been upfront in most of the ophthalmic treatment. They requested me to talk this. So I'll be talking about resistant to resistance, choosing the right antibiotic in ocular infection. So this is my financial disclosure, especially for this particular talk. I think I am consultant for Allergan India. So I think for introduction, I think these are the few extraocular infection you see. I think this is what we studied in, I think all come across, all of us, like patient might be having a blepharitis, dacrocystitis, conjunctivitis, bacterial keratitis, orbital cellulitis, chalazion, and hydiolum. These are all the extraocular infection which is responsible for these intraocular infections, especially end of uveitis, chorioretinitis, even choroiditis. So let me, I think today the main concern is most of the organisms are resistant to most of the antibiotic. So we need to really find out which antibiotic is really sensitive to most of the microorganisms. If you think about it, might be in individual cases, in the society, and of course is very important in managing the infections. So today I'll be talking about one particular word that is nothing other than the minimum inhibitory concentration. This is nothing but the lowest drug concentration by any drug which inhibits the growth of the organism. I think which is this MIC, that is minimum inhibitory concentration testing, has been used for decades to guide the antimicrobial therapy and remains as an important measurement for the infectious disease. So a microorganism susceptible to any antimicrobial agent indicated by a low minimum inhibitory concentration. So these are the drugs we use in ophthalmology. I think still a lot of my friends been using gentamicin, tobramycin, we use becifloxacin, then comes the gedifloxacin, moxie is there, cipro, still a lot of my friends been using levofloxacin, azithromycin, polymyxin. These are the few antibiotic we use in ophthalmology. So which should be the choice of antibiotic? This is very important. It should be broad spectrum, bactericidal, with a good tissue penetration, with a low toxicity. It should be fast acting agent. Suppose if you think about, okay, this third generation fluoroquine predominantly bind either to the DNA gyrase or topoisomerase IV. But the latest fourth generation fluoroquine, which has got a dual mechanism action. That means it binds both DNA gyrase and also topoisomerase IV. So what should be the choice of antibiotic? What are the parameters for selecting a good anti-infective? It should be broad spectrum. It should be less toxic and a less dosage. We have to put a very minimum time. So coming to the, probably if you see a lot of studies, I think fourth generation is always fluoroquinones are far more active in vitro than the third generation fluoroquine, as you can see in the picture. So compared to, see now the third generation fluoroquine against the fourth generation, the study showed here in vitro, especially gedifloxacin showed 26% higher susceptibility compared to the moxifloxacin. That means gedifloxacin showed a higher susceptibility towards third generation fluoroquine, which is compared to the moxifloxacin. So this was the study actually is being done in one of our friends' hospital, that is Joseph's Eye Hospital, Trichy. See what they seen, that spectrum of keratitis in India. So commonly implicated bacterial and ocular infections are more susceptible towards gedifloxacin than the moxifloxacin. Then if you see, this is also one more study from India only, I think from our friend Namrata and the team has done this. If you see that, I think Tirumalesh also, I think that time he was there in the same institute who has studied from RP Center. What they say that most common gram-positive organisms are susceptible towards the gedifloxacin, but both gram-positive and gram-negative ocular isolates are more susceptible towards gedifloxacin than the moxifloxacin, which is from the Prime Institute of India. Okay, so what should be the bacterial resistant mechanism? Normally, fluoroquine resistance can develop either through mutation in the DNA gyrase or mutation in the topoisomerase IV, as I already told you. So if you see here, in vitro study of antibacterial susceptibility to commonly used antibacterial agent, I think Staphylococcus aureus is the most prevalent organism across all. So most of the bacteria isolates were susceptible to gedifloxacin. That is almost around 83.76% of the cases. So if you see here, higher sensitivity and lower resistance indicates that gram-positive isolates show a lowest resistance to gedifloxacin. This is very, very important. If you, as I already told, that the MIC value, which drug has got a lesser MIC value? I think, of course, gedifloxacin have a less MIC value, minimum inhibitory concentration value against Staphylococcus aureus, which is the main culprit here. Even it shows even a least MIC value against one of the deadly organism, that is a Streptococcus pneumoniae. So this is how it acts. I think I'll not talking to this after the installation, how drug will really act. But what I want to say, the concentration of the gedifloxacin in the aqueous swimmer were significantly higher those of moxifloxacin at the end of 3.5 years. This is very important. Which drug has got a more penetration? Of course, gedifloxacin has got a better advantage. Of course, if you can, of course, gedifloxacin, even 0.3% significantly better tolerate than the moxifloxacin. Then speed of action, this is very, very important. In most of the cases, even if you install a drop of gedifloxacin, I think within 15 minutes, I think except Staphylococcus aureus, the organism, it will kill the organism. I think gedifloxacin 0.3% eradicates bacteria that commonly causes ocular infection, definitely faster than the moxifloxacin. This we have to keep in mind. As I said, that speed of action definitely is much, much better compared to the any other patient. But this is about the patient where has done a keratoplasty. Post-operative use of gedifloxacin, especially following a keratoplasty patient, may allow early stage of corneal graft reepithelialization to proceed more quickly than other drug treatment with the moxifloxacin. This is important, and people started even using already undergone the penetrating keratoplasty. So, of course, this rule, always we talk about the preservative drugs. Okay, let me talk about here, gedifloxacin 0.3%. It has got a very minimum, I think, it is not a preservative free, it is a preserved with a BAC 0.005%. How BAC will help in combination with the gedifloxacin? It completely eradicates the staphylococcal isolates more rapidly with BAC free formulation. So with gedifloxacin, you need to have a BAC 0.005% than the preservative free drug. So coming to the dosage, Remy, I think probably if you think about, okay, all this time I was talking about gedifloxacin 0.3%, but gedifloxacin 0.5% administered twice daily for even people are now started using for treating acute bacterial conjunctivitis. This is very, very important. So gedifloxacin ophthalmic solution 0.5% always safe and effective for treatment of any of the ocular infection. In summary, antibiotic resistance is a global concern, we all know. But very important, which drug has got a minimum inhibitory concentration that indicates a higher potency of the antibiotic. Higher the sensitivity percentage and the lower resistance percentage indicates that gram-positive isolates show a lowest resistance to the gedifloxacin. Gedifloxacin has a least minimum inhibitory concentration value as compared with any other agent, indicating higher potency of the antibiotic, slower rate of resistance, and which is significantly better tolerated in ocular penetration and a faster speed of action than moxifloxacin. The gedifloxacin solution is a 4th generation fluoroquine with the BAC preservative and broad spectrum activity and had relatively low resistant profile. Once again, I thank Allergan India for this opportunity. I thank Thiru for this moderation, and I thank you one and all for the opportunity. Thank you.
I think thank you very much, sir, for that excellent talk. And
I think you are the greatest veteran surgeon of our Karnataka Ophthalmic Society. Any doubt? Any questions from your side? Also, I am open for this.
Just one question, sir. Do you, in your practice now, use more of gedifloxacin these days, sir? Because I do use it more than mox.
Actually, my cornea person, actually for treating a corneal ulcer, I have not seen them treating, but all my patients pre-op antibiotic, especially one day before, I tell the patients to, of course, there are a lot of study, you don't require to put a pre-operative antibiotic. I think just a half an hour before, if you put a drop of povidone more than sufficient. But I am always safe. I give the patient, of course, the same brand name of the gedifloxacin, BD dosage, Zymaxid, one day before the surgery, then I take them for surgery.
Oh, that's wonderful. Dr. Dipendra, would you want to add any comments, sir? I think he's away from this thing. Dr. Sonu? Sir, any comments from your side, sir? Okay. So I think I'll just make a quick call to Dr. Dipendra so that we can start
Thiru, I got one more, this one, I'll be logging out. Don't mind.
Yes, sir.
No?
Yes, sir.
Yeah.
Thank you, sir.
So much. Thank you so much.
Hello.
Dipendra, sir, we'll start the surgical nightmare session, sir.
Yeah, sure.
Okay. So for the posterior segment surgical nightmares, this particular session is to, look at, many a times we feel that VIA surgery can go very smoothly, but what happens when the board starts rocking. So this particular session is about, what to do when the complications happen and how to manage. And for the first video, we have Dr. Dipendra Vikram Singh here. He's a VIA surgeon who's trained from All India Institute. We belong to the same alumnus. He is director of IQ Hospital. He's the chief VIA surgeon there. And he handles most complicated cases, with reference to my seniors that I have seen. I welcome Dr. Dipendra to start the session and show us a video. And, we would like to have a discussion the moment the video is finished. Dr. Dipendra, over to you.
Yeah, thank you, Dr. Thirumalesh and Dr. Ilan for inviting me. I hope my presentation is visible. And
Yes, doctor.
Is it visible?
Yes, doctor.
And I hope I am audible also.
Yes, doctor, it's clear.
Fine. So I think because Thirumalesh asked me to share some of the nightmares, so it's although you never forget your nightmares, but then when you recall, so in recent past, I could remember this one of these cases, and this was actually uncle of a very renowned orthopedician, and he was 67-year-old, and he had a history of pars plana vitrectomy done elsewhere for dense vitreous hemorrhage, as per records, and but he couldn't recover any vision after surgery. So and then he himself didn't seek any other opinion for next 3 months, and when he presented to us, so picture was like this. It was like total cataract and PR inaccurate 3 quadrants, severe hypotony, and when we did ultrasound, there was a total retinal detachment, and we were thinking that probably it is PVR and probably redetachment after vitreous surgery. We did a B scan. There was some hyper-echoic lesion appearing in subretinal space. We couldn't make out what was it because the anterior segment was totally untouched. And so we thought maybe it is some cyst or some mass lesion. So I was little hesitant to operate him, but because he came with so many reference, everybody said, you just give him a try. So this is how this surgery went, and we did as our routine 25 gauge surgery. Because PR was inaccurate, we were not planning any lens. So plan was to do a lensectomy rather than phacoemulsification. You can see the free flowing fluid like you see in vitrectomized eyes. Now, one thing was very surprising in this case, that lensectomy was over very fast. And I was really surprised that for a 70-year gentleman, how can this nucleus and other things be so soft? But even at that point, I couldn't imagine that what lies next. And it was like total RD with PVR and a large iatrogenic break seen superiorly and contracted retina. So as we do in these cases, started peeling from posterior pole towards anterior. And after I have opened up the posterior pole, we start putting this PFO. We realized that there was a break here also in the macular area. And it was at this moment we realized that there is a free floating mass in subretinal space. And because of the size and shape of the mass, now we could make out that this is a large nucleus. So this could have become a nightmare if we were not prepared for it. If we didn't have phacofrag, then this much nucleus in a 70-year-old man can be difficult to be removed by cutter alone. One challenge was how to manipulate it. So I changed my hand and I used this aspiration technique, I think, which is favorite of Dr. Shubhendu. He will hold IUL also with this aspiration technique by soft tip. And obviously then you do phacofrag and peel internal limiting membrane just to make sure that posterior pole is not stiff. But then when you start fluid air exchange, as we could judge initially also that retina was contracted and taut, and air goes subretinal. So again, we had to do almost 180-degree retinectomy. So finally, retina was reattached, endo laser with silicone oil tamponade was used. And this gentleman is doing good so far. I think you can see the fundus picture at 10 days follow-up. He is maintaining 6/60 vision. So I think I'll just stop here. And because the case was operated somewhere else, we were just thinking what could have gone wrong, because this is I have seen first time that anterior segment not touched and you still have subretinal nucleus. So possibility is that because of dense vitreous hemorrhage and maybe the choroid was thickened, the cannula became subretinal, and it led to a bullous detachment. And surgeon tried to maybe initiate vitrectomy, and in the process iatrogenic tear was created. And then to negotiate the bullous RD, probably he went to anterior, and the cutter could have hit lens and nucleus, and that is how it could have been shoved in subretinal space. So point is, I think this I would like to share. I hope there are few young retina guys who are listening. One prevention tip is, if you have a slightest doubt that your cannula has gone subretinal, I think first thing one should do is remove that cannula. There have been techniques described, people have seen in 20 gauge days, that you start manipulating from the other side. I never ever do it. Whenever I have a doubt that my cannula has gone subretinal, I'll just simply take out that cannula and choose some other site which is much more anterior. And then next time I confirm it with a light pipe rather than putting an infusion. So that is a very important step to prevent this nightmare. And second is, when you are handling these kind of cases which have a history of a vitreous surgery being done or a complex cataract surgery, keep all your gadgets like phaco-frag, and if you are suspecting a foreign body, magnet, forceps, everything ready. So VR surgeon has to be ready. So that's it from my side. Over to you, Dr. Thiru.
Yeah, it was a very interesting case, sir. So when would you suspect that a particular case has probably has more complication than you expect? So when you made the port, you saw that there was fluid coming out. So
Right.
at that point of time, did you initially suspect that it was a vitrectomized eye and there was something wrong, sir?
No, the history of vitreous surgery was clearly there.
Okay.
It was like anterior segment surgery was not done. So it was difficult to imagine that nucleus would have gone posteriorly. It's in subretinal space. Normally you would have expect if a surgeon had posterior capsular rent, then you can imagine that he was trying to patch it, and it would have gone subretinal.
Okay.
But it was like VR surgeon has done the vitrectomy and vision didn't come, and patient comes with mature cataract and a detachment. So surprising thing was that nucleus was missing, but anterior capsule was intact, and it was hyper mature cataract. So you couldn't see the nucleus otherwise also. So I think doing ultrasound is a good idea. Ultrasound gave us some clue that there is something in subretinal space. Be prepared. And second is some things will come unexpected. So you have to keep your endothermy, magnet, forceps, phaco-frag, all your accessories ready.
That's correct. Sir, when you're maneuvering the nucleus, because in the initial part of the video, the tear was a little away and the nucleus was on the other side.
Yeah.
So for people like us who are initially doing it, what are the tips for us to, how to move it towards the break? So would you use a PFCL jet to move it, or would you use a second instrument to move it towards the breaks?
I think the situation is not very common, but in this particular case, because there was subretinal fluid also, nucleus was free floating. So one gentle push and it was easily coming up. Otherwise, with such a large iatrogenic break, you can actually go all the way from the other side in subretinal space and aspirate and take it out. Only challenge would have been if we didn't have phaco-frag. If somebody is not ready with fragmentome, then it would have become a little more tricky to bring whole thing into anterior chamber and take it out from limbus, which we never do for last more than a week.
So if the phacophrac is not there, then methods would be probably fill it till the brim and then extract it by making the tunnel.
I think at this time I can suggest one more thing. Even if you don't have phacophrac ready, you can always keep a long, and you can always fix it to your routine anterior segment phaco, and it works beautifully. And all you have to do is, and even if you don't have a long phacofrag needle, your routine phaco needle without sleeve and without irrigation can be used, but then you have to put PFO to bring nucleus upwards. So these are all small tips. If you don't have phacofrag, you can use your anterior segment phaco also, but has to be used by a trained VR surgeon.
Okay. Dr. Piyush, would you want to ask any more questions or any comments on the subretinal nucleus that we had? I think multiple conferences and people are multitasking.
Yeah, I can make out.
Yeah, I know.
So it was, I think, a pleasure to see you, Thiru, after a long time. And Dr. Shubhendu is not there.
He's still logging in. I think most of them are still in their OTs. They're trying to, it's been a very busy day for the VR surgeon. Vishal is still operating. So is Dr. Prashant, and so is everybody else.
I can understand. I also have to go to OT, so these guys are
my
busy.
God. Yeah. So very busy day. I think we have caught all of us on the wrong day. So
no, that day is perfect, and thank you so much.
Thank you, sir. Thank you so much.
Thank you so much. Okay, all the best. Thank you.
Sir. Thank you. So I would welcome Dr. Piyush. Dr. Piyush Bansal is founding director of Bansal Eye Institute. He's serving AOS and the Maharashtra Ophthalmic Society in various positions. And Dr. Piyush, you are ready with your video?
Dr. Thiru, can you give me 5 minutes? I'll just run upstairs.
Sure. Okay.
Thank you.
I think we'll just have to wait for 30 seconds because all the superstars are like a little busy in the OT and probably getting on to this thing. Saujanya, can you allow Dr. Shubhendu Boral to be on the panel, please? I think he's not able to. He's not showing on this thing, but he's been logged in for some time.
No, sir. I'm unable to see him.
Hero, I'm there.
Is it? Okay. So in the meantime, I would welcome Dr. Prashant Bawankule. Sir is a well-known figure who does not really need an introduction. And, he's serving the ophthalmic fraternity both in the Maharashtra Society and the All India level. So we welcome Dr. Prashant. Sir, kindly, take over and please present your video.
Thank you, Thiru. Well, good evening, friends. Here I am going to share you certain interesting case. This is a video bouquet of intraoperative choroidal folds. Hope I am audible. I'm in a public place. I'm in a conference. So am I audible, Thiru?
Yes, doctor. Yes.
You're audible, sir, very clearly.
Okay. So this is a video bouquet of some cases where we had intraoperative choroidal folds and how it was managed and what we learned from it. Let's move through the presentation. So these are the causes. We know predisposing factors are advanced age, high myopia, previous scleral buccal placement. Sometimes you have intraoperative development basically because of infusion cannula into the choroid or a hypotony or intraoperative hypertension. These are the steps which are prone for choroidal folds which have been documented into literature. Just let's move directly to the case. This is case 1 where I am just doing infusion cannula. I confirm the presence of it, and yes, if I see that it is not into the thing, and how we can avoid is put a next infusion cannula and then proceed with the case. And this is how you can avoid. Case 2, this is a 80 years old male who was present, who had been posted for epiretinal membrane surgery. And as you can see, if you come nasally, you can see such a large choroidal mounds. In fact, this patient was just posted. So what we did was at this point, we increased the intraocular pressure intermittently, because at low IOP of 30 millimeter, it was causing more severe choroidal folds, not letting us get an adequate vitreous space. So after increasing the infusion pressure at say at around 50 millimeter intermittently, we could manage and we could do the epiretinal membrane and complete the surgery. So what we learned from this particular case was, this was later on when we retrospectively moved through it, this was a patient with a small orbit and a big globe. And we had given a infusion, like a retrobulbar infusion of more than 10 millimeter to make that eye akinetic. And that was the reason of that folds coming so severely. So in a tight globe or in a tight orbit with a larger globe, it is preferable to use less means pre-op anesthetic agent. Well, the next day the folds subsided for our good luck. Case 2. This is another person who was undergoing a vitreous procedure for epiretinal membrane or some macular procedure. And as you can see, when we started doing peel, the patient started moving over here. And because of that, the ILM peel was not safely possible. So here I'm injecting another retrobulbar. And after injecting, you can see severe choroidal folds. Though we could achieve an akinesia, but the membrane, you can see large folds. We had to work under slightly high IOP, and we could achieve complete the surgery in these cases. So remember, whenever you are trying to give supplemental anesthesia, you have to be doing quite minimal in volume. Otherwise, this can lead to volume-induced changes. Now, another case, this is a case of a macular hole where you can see that while induction of PVD. Now this, I am trying to induce PVD and suddenly you can see the choroidal mounts appearing on this nasal side. Now this choroidal mounts is because of the mismatch of the infusion cannula, that is the infusion, the fluid which is coming in, because we were doing under 25 gauge, and if you use a low IOP setting, well, it leads to the mismatch of ingress versus outgress of the fluid. And so especially in smaller gauge equipments, you should remember that you have to raise the bottle height or raise the intraocular pressure when you are doing a steps like PVD, otherwise it leads to choroidal detachment. Now this is a case of a retinal detachment which is in a progress, and as you see, when I have completed the PVD has been induced, ILM has been peeled off, and I'm putting. Now the fluid air exchange is done, that is PFCL air exchange is being done. And this is the step when I'm trying to do interface vitrectomy. And you can see while doing an interface vitrectomy at a high suction rate, you can see sudden appearance of the choroidal mounts. And at the conclusion, we could see a large choroidal mount as a residual when we completed the fluid air exchange. So this frequent change of IOP pressures during fluid air or PFCL air exchange, you have to be very careful, should not be in a hurry. Well, how did we manage? We did the laser first into the breaks and other part of the retina, and over the choroidal mount, you have to avoid doing laser, otherwise this goes on exaggerating. Now, this is another case of a aphakic retinal detachment where again, you can see after induction of a PVD, the vitrectomy being done. And here, you can see the choroidal mounts have started appearing. Well, we were at the last end of the thing, but you can see at the conclusion of PFCL air exchange, when I'm seeing, I could see a large choroidal mount. Again, the tip over here is if you ever have, because of whatever mismatch or such choroidal mount, do minimal of the laser as a retinopexy. Do the laser first in the non-choroidal area, and last you should do over the choroidal mount, and that too if necessary, like if you have a break or a lesion in that area. Now, this is another interesting case here. Well, another case of a retina detachment. You can see I'm depressing the patient, and I did the depression, and here you can see PVD and the other steps of retina detachment, and you can see the choroidals over here. You would wonder what is happening to me, is how so many choroidals I see. But yes, these are few of the cases over last 3-4 years which I've collected just for sharing the knowledge how it can happen because of mismatch, especially in smaller gauge instrumentations. And you see the large mounts over here. This, I'm trying to drain the fluid. I did the barrage into the other area. This is the break over that choroidal mount. We did it. And we did the complete PFCL air exchange, and you can see the choroidals pouring into the posterior vitreous, into the posterior pole. We did the silicone oil, and fortunately for us, the next day the choroidal subsided with simple use of steroids and proper management. Now this is another case of this video. Sorry, this is the last case in this video bouquet. I'm sorry. Yes, in a case of a detachment, PVD induced, and here PFCL being put. I'm trying, you can see a large choroidal mount over here. I'm trying to do whatever peripheral vitreous excision over here, and suddenly I see conjunctival pouring. I am not understanding why there is a choroidal mount. I'm trying to explore. I see the conjunctiva ballooning over here. I thought it's a conjunctival chemosis, which was causing accumulation of fluid over the cornea, not letting me get a good view. So I drain it with the help of a 24 gauge needle, hoping that the choroidals, that I would have a better view. But what I see is that the choroidals are somehow not decreasing in, means to the extent which I would love to see and manage the surgery. So again, I go back and see, try to, sorry. What happened? Yeah. And again, I go back, I do a air exchange, I see a large choroidal mounts. I'm a bit worried at this point of time. I do PFCL, and I try to see what is happening. I try to put the PFCL hoping that the choroidals will drain other day. But what I see here is the silicone oil into the subconjunctival space. I check for the infusion cannulas, whether they are intraretinal or it is also everything is in place. And here I find something fishy. I'm not understanding why this oil is pouring out from this area subconjunctival. I'm suspecting a break. Now, after this, I try to explore that area, trying to understand why is this happening, what is the problem, and look, when I dissect the conjunctiva over here, I see that staphyloма over the thinner sclera, which was staphylomatous, has given away, leading to a large sclera rupture, which might have happened during when I was trying to depress during the base excision. So I repaired the thing. After repairing, I go back inside the eye. The choroidals did persist for a while. We injected silicone oil under positive pressure in this particular case. And fortunately, after use of oral steroids, we could achieve a good retinal detachment surgery. But what we learn from this is when you're doing a base excision, especially in a high myopic eyes where the sclera can be thin, bluish, try to be very gentle. Otherwise, you can lead to a sclera rupture leading to choroidal detachment. And well, this is the last video of this particular book. A young patient, hypertensive patient whom we did post for vitrectomy for detachment, primary vitrectomy being done. And see, we are at the conclusion of the surgery. Here I conclude, I give over my case to now my resident over here and ask her to close. And she calls me back, sir, there is something choroidals which is happening. By the time I re-enter, I see the whole choroidals have blocked the view of the posterior pole, even the disc. And it was nothing but a suprachoroidal hemorrhage. I thought, let us try to do at least laser, complete the laser to this break and one more break, which was inferiorly, but the mounts kept on increasing. And after certain time, you see there is some blood which is pouring into the cavity wall. Well, now everyone knows the diagnosis. This is a case of a classic suprachoroidal hemorrhage, and we had to rush through it. There is a heme inside the antechamber. We close it rapidly, and 2 to 3 weeks later, we drain the choroidals and complete the surgery. So friends, intraoperative choroidal folds can happen because of multiple reasons, right from mismatch of infusion cannulas to the drainage devices, because of the wrong placement of it, hypotony sudden, or sometimes you pressing the sclera over a thin sclera leading to rupture of the sclera, and very rarely a suprachoroidal hemorrhage. Thank you.
I think that was a brilliant bouquet of cases, Dr. Prashant. You did show the wide variety, where there is just a mismatch of ingress and egress to, aggressive indentation and probably giving away of this thing. With reference to the case where there was a giving away of the ciliary staphyloma, I think Dr. Borrell had presented a very, very similar video where there was I think, displacement of the cannula. Borrell sir, would you want to comment on the video that Dr. Prashant showed?
Yes, displacement of cannula means sometimes suprachoroidal may happen. You don't know when you have seen the tip of the port is there, but basically slight choroidals were there. When you are seeing the tip of the port during the vitreous, after depressing the vitreous base, you have seen the tip of the infusion port. But again, if you just release the pressure, the tip of the cannula again go back to the suprachoroidal space or in the choroidal space. So that may happen. You should always check repeatedly what Dr. Prashant was telling. You should always check intraoperatively repeatedly to check the tip of the infusion whether it is intravitreal or not.
Yeah, point well taken. Dr. Prashant, with reference to the last case that you showed where there was a suprachoroidal hemorrhage, what are the tips that you would want to give? Because getting a SEH in a small entry kind of a VIA surgery situation is a very, very rare occurrence. So what are the things that you think probably, in the postmortem examination of the case, you would have found a few things that probably went wrong. So what do you think was
I
the
would
problem?
accept that. See, this was a young hypertensive male who came with a partial retinal detachment, and he was hypertensive. His BPs were slightly on a higher side. His diastolic, when we sent him for PAC, was around 100. We forced him with, some anti-hypertensive agents pre-operatively because we wanted, it was a macula threatening detachment. We wanted to take him early. We asked the anesthetist to give him a dip-in and all those things. What other thing is, so sudden bringing down of blood pressure is not very good, especially in a younger hypertensives. That's what I feel. Second thing, what I did wrong in this case was when I transited, like I had completed part of the endolaser treatment to the horseshoe tear, and then I wanted my colleague to take over and complete the laser and do that. When I transited at this particular point, I should have plugged the cannulas, which was my mistake. See, I left that eye, and when it is not a non-walled cannulas, it leads to sudden hypotony, even if in a FX situation. And this is what I presume were the two reasons which precipitated that. So I take the onus of this particular case.
No, I think you make a very valid point, sir, because during doing a VR surgery, surgeon has to be extremely aware of his surroundings. So right from, like Dr. Boral said in his case that, there was the cannula just went back. Majority of the times when when the lens is being put and removed, there might be a slight displacement of the cannula if you have not fixed it with a plaster. When in our training days, our mentors used to be very, very angry that, we did not put that plaster and kept it in a particular way. And that does serve a purpose now. And many times, many people used to tell us that, you remove it and the water is coming on either sides during an SOR like a fountain. Not closing that can cause these kind of complications. So all these small things matter during a VIA surgery. And thank you very much for bringing to our notice that, these are the small things that one should definitely keep an eye on when we are doing surgery. And also thank you very much for making time for us in between a very, very busy schedule. Thank you, Dr. Prashant.
We had our Vidarbha Ophthalmic Society meeting. We had general body meeting. I was chairing, and suddenly, I'm really sorry for missing it out. I'm really sorry.
Thank you so much, sir. Thank you so much for still making it.
Yeah, thank you.
Thank you so much. Thank you so much. So I think we have another very busy person who would probably want to, finish the video. Piyush, please go ahead with your video presentation.
Thank you so much, Thiru. It's really an honor to be over here. Thank you for the invite, Dr. Thiru and Dr. Ilan. So it's always tricky when you have multiple conferences going on at the same time, and we have the Pune Ophthalmic Society and the Vidarbha Ophthalmic Society meetings also going on right now. So can I begin? Can you see my slides?
Yeah, I can see your slides, Dr. Piyush. Please go ahead.
I'll be showing a couple of cases which are essentially intraocular foreign bodies. They're always tricky to remove intraocular foreign bodies, and you never know what you might encounter. So many times you've got to think out of the box because you have to think out of the box. One second, I can't. Yes, so I'll be showing a couple of cases. You have to essentially keep changing your strategy depending on what kind of foreign body you're expecting or what kind of, whether it's impacted, whether it's in the pars plana. And the first case over here is an intravitreal pars plana iron foreign body, wherein the vision.
Piyush, we lost your audio. Yeah, now I can hear you, I think. No. I think again it's on mute. The slides are moving, Piyush, but we cannot hear you. No, not yet. Can you check your mic again? No. I'll do one thing, Piyush. I'll go to the next speaker. I think we will allow Dr. Shubhendu to present it. Can you re-log in so that we'll do this again? I'm not able to hear you. Yeah. So we regret for the slides and the audio part. I would probably like to now welcome Dr. Shubhendu Burul for presenting his video. As we all know, Dr. Shubhendu Burul is a very senior VR surgeon from West Bengal. He has been very active presenter in most of the VRSI and AAOS retina sessions. He's a very senior surgeon and very experienced in the VR field, and he's known for presentation of these complicated VR scenarios. Dr. Borel, please take over, and we would want to see the presentations you have.
Thank you, Tirumales. So it's a very unfortunate situation for Tirumales. For Piyush, I think he has lost his audio. That's why. Coming to my topic, it is the complications in macular surgeries. I will share my few of my complications. Like they are very unique. Like in my first case, macular ERM turned to retinal detachment. Like it was a case of macular ERM, simple case. I did vitrectomy and then stained the ERM. And after staining the ERM under air, when you put the infusion on again, they have seen the track of fluid. It was subretinal fluid going to the periphery, and macula is quite looking boggy. I checked twice the fluid, the subretinal, there is a track-like situation going towards infratemporal quadrant. Towards the infusion port, I was not sure what has happened, but whatever surgery was planned, I removed the stained ERM, and my feeling was it was just like I am operating on in a case of CSR. Like it is because maculas, it is a very boggy-like situation. It is very feeling, and you can see the serous kind of detachment is there. Suddenly, the whole retina was detached. It is the intraoperative complication during macular ERM surgery, and the whole detached retina is just behind the lens. So I injected PFCL heavy fluid to settle the retina and then started doing fluid exchange. And I discovered there was a break in the infusion port area, where that means the infusion port has created a kind of not dialysis, maybe even more, it is maybe break. So I filled the whole cavity with the help of PFCL, settle the retinal detachment, and finish the case with oil. And I've seen it was just more than 4 millimeter. That means maybe it is perforating the retina, or there is anterior insertion of the ora serrata that happened in this situation. So these are all not in your hand. This kind of situation may happen at anybody's end and any time. So intraoperative macular formation, coming to my second complication, where there is submacular hemorrhage, and it was quite elevated. So I planned for vitrectomy along with injection of subretinal TPA and cocktail injection of air and ranibizumab. So I first injected TPA injection, waited for some times, then again injected mixture of ranibizumab and air, and just see what is happening. There is a gush of blood is coming out through the macular area, that is hole formation, intraoperative macular hole formation. But so now what to do in this kind of situation? I started doing fluid exchange. Should I drain the whole blood? But again, I will remove the subretinal TPA. I will lose the retinal TPA as well as the whole anti-VEGF injection as well as air. So I just do some kind of drain the whole area little bit, completed the fluid exchange. And post-operatively, I was very lucky that there was no macular hole, vision improved to 6/18, and there was complete regression of after 2 months regression of whole submacular blood, and there was no macular hole formation. But every time you may not be fortunate, and I was not fortunate in my another case where after after doing all this procedure, cocktail injection, I faced the macular hole formation. After 3 weeks, then my plan was to do the ILM peel with inverted flap technique. Here I stained the ERM and ILM, and I checked the macular hole whether is it draining, is the blood, subretinal blood will come out or not. Then I started doing inverted flap technique, like peeling the ILM away from the macular hole and keeping a hinge of ILM around the macular hole temporarily. It was kind of minimalistic approach where my plan was not to complete the whole ILM around surrounding the 360 macular hole. I just did elevated the temporal flap and did fluid exchange, just keep the flap just overlying the macular hole and drain little bit, and hole was nicely covered the macular hole. And postoperatively, again, I was lucky enough to get this kind of situation on retina, and macular hole is totally closed. So this is another case where intraoperative tear formation happened during macular hole surgery. It was again a case of inverted flap technique. So I stained the ILM and did inverted flap technique and removed all the ILM all around in the ILM field area, and did fluid exchange, and then tried to reposit with the silicone tip cannula. My air pressure was a little bit high. So at first stage, I lost the ILM, nasal ILM flap. So again, I tried to reposit the rest of the ILM with the help of Tano scratcher. Again, just see there is tear formation at the whole margin with the help of, it's due to the Tano scratcher. So what I did, I waited for something and put the whole blood clot over the macular hole. Postoperatively, the macular hole fortunately become closed, and you can see from all angles there is hardly any tear is visible. And after 4 weeks there was complete type 1 closure of the macular hole. So this is another tricky situation where there was scleral esophageal and recurrent retinal detachment due to paramacular hole formation. There was esophageal was there, and there was total retinal detachment. Detachment happened due to the paramacular hole formation. This hole is there, and retina was a little bit contracted. I tried to stain the ERM or ILM, whatever membranes are visible, to remove all the residual membranes. These are all PVR membranes, so removed all the membranes, and if there is any membrane is present around this paramacular hole, I tried to remove that and marked the paramacular hole with the cautery. Then again, I started doing fluid exchange, creating a nasal retinotomy. Just see here, I have started doing the doing fluid exchange, but this paramacular break is suddenly becoming increasing. I have not touched this break, but now I am just did little bit of fluid to then now see there is subretinal air that has gone inside. That means any kind of contracted element must be there. I try to remove the air, but suddenly the hole become totally enlarged, and I started infusion on again and injected PFCL. Let's see what will happen. And now this is a series of complications happening. Now PFCL gone inside the retina. So it's a very tricky and very dangerous kind of situation. So I just did retinectomy temporarily, what to do, and removed all the subretinal PFCL as well as air, and then fortunately settled the retinal detachment. Now, how to cover this large macular break? So here, when I was taking time to have a thought what to do next, I took one large graft from the peripheral retina, and with the help of a Finiciflex loop, I harvested this graft from the superior temporal area to cover this giant macular break. I should call it giant retinal macular break because this is anyway is larger than the maximum size macular hole, I think so. So I was not sure should I keep it as such or not, because the hole was not covered with only totally with this graft. I did a little bit of laser surrounding and the retinectomy site, and I was very much fortunate. The retina was absolutely on, and the graft was absolutely in situ position. Posterior vision improved from the preoperative vision. So another thing, intraoperative foveal tear formation during subfoveal tear cell removal, it is also a very tricky situation where there is a large subretinal subfoveal tear cell bubble, and after removal of this silicone oil, I took one metallic 41 gauge trocar cannula blade, 41 gauge subretinal needle, and suddenly the eyes there a static movement started because the periorbital block was going, and the patient was not complaining of any pain, but there was movement. So I thought then this can be removed. So I tried, but suddenly this tear happened accidentally due to the movement of the ocular movement of the eye, and then I did very well the subtenons block to do the anesthesia, more anesthesia, and then I stained the ILM again, and Then I tried to remove this subfoveal tear cell bubble. Sorry, it is no. So, and tried to remove this tear cell bubble, and it came out from the subfoveal area, and then I removed the tear cell bubble, and then stained the ILM and did inverted flap to cover this tear, and patient was very known to me. Unfortunately, with this technique, inverted flap technique, the macula was absolutely okay. There is no subfoveal bubble, tear cell bubble, and there is macula hole is absolutely closed. This is another case of autologous retinal graft for open macular hole. It was a very large kind of macular hole, post-traumatic macular hole. I did vitrectomy, and there was open macular hole posteriorly. So in this case, as usual, I injected the tear cell bubble and marked an area of superior to the disc, and enclosed area of autologous retinal graft has been taken with the help of phenoceflex loop. This phenoceflex loop, I am very fond of this loop because to harvest this graft, autologous retinal graft, and deposit this graft overlaying the hole. It was upside down. Now again I made it upside down again, just to keep the ILM facing intravitreally, and then deposition the whole graft. And then I did more laser around the harvested area and injected a little bit of PFCL here, then started doing silicon and PFCL exchange under the cellular slide. This is silicon and PFCL exchange, and finally I removed the PFCL bubble, and the graft was in situ, and nicely the hole was closed, and vision improved to 6/24. This is another complication happened due to the perigonal block in a case of high myop. My plan, it was a case of myopic foveoschisis with ERM with vitreomacular traction. My plan was to do the cataract surgery, vitrectomy, ERM, and ILM removal. I did a vitrectomy, but while going and while after going inside, I seen a lot of hemorrhage. Was there? It was should not be there. It was beyond my expectation why this hemorrhage happened, and however I have to remove this pre-retinal blood. Chunk of blood, I removed it, and I've seen that there is a large tear happened inferiorly, So how does it happen? So must be some kind of wrong site periverbal block has been given. So I made injected the dye because of quite old video. I injected Pvd dye under air. Nowadays, for last few years, I'm injecting dye in the only in water, in saline. So here I started the infusion again and keeping my soft tip cannula just over, but again, this detachment happened separately. So there must be some kind of break. You can see the multiple break separately. That was the secondary break happened during the periverbal block. So I removed all the ERM and ILM for the myopic foveoschisis area to treat this myopic foveoschisis. And finally, macula was absolutely free of this ILM. And then I started doing fluid exchange to settle this superior RD. And through this break, I drained the whole subretinal fluid, did laser for the superior breaks as well as the inferior breaks, and ended up the case with the help of gas only. After 2 weeks, the foveal contract was nicely improved, and after 6 weeks, vision gained to 6.9. Thank you.
I think it was an excellent presentation. Most of it takes a lot of courage to show the complication in public, and I think nobody does it better than you, Dr. Bural. And you did show a lot of complicated cases and intraoperative complications and how to come out of it. I think that is a lesson in itself. So
that is the most important thing. Like you may face complication, but how to come out of it is the most important thing.
That's the most important thing. Yes, if you don't know how to come out of it, then this can happen any of the time, and you're flummoxed most of the time. So looking at your videos, most of the times I do end up learning very, very important things by the end of the video bouquet. So my question to you is that when you are putting an autograft, in case of a macular hole, or if you have an iatrogenic tear at the macula, do you oversize it, sir? And what is the kind of oversize that you kind of do?
At least 1.5 times oversize should be, like the size of the graft should be more than 1.5 size of the maximum macular hole diameter. But in my former, first case, that was a very large break. So I have to take the graft from the periphery. That size I couldn't measure. That's why I accidentally, the size of the graft was smaller than the size of the macular hole, macular break. I should not call it macular hole. It is large macular break, giant macular break.
Thanks.
It's a horrible situation. Yes.
Yeah. The second thing that I wanted to ask, sir, was that do you think the retinal stiffness was because of a very thin hyaloid layer, which tends to pull more and more, when you start air?
No,
and
basically, initially I removed all the pre-retinal, all the vitreous, but there was intrinsic retinal contraction around the paramacular break. That was the responsible factor. Because of that, the whole size suddenly becomes enlarged, and there was some retinal hair, and all the cascade of reaction happened. Apparently, looking very simple case, I will drain the fluid from the nasal area and do some kind of laser and the paramacular break. But suddenly it becomes giant break. So that was very shocking kind of experience.
I think take-home message from this is that no case of VR is a simple case.
No.
Every case, anything can happen. Last question to you, sir. You say that now you are staining your macular holes under fluid. Even I stain under fluid all the time. I have never done staining under air. But we have commonly seen that, in the common cause of why a tear happens is that when you switch on the fluid, there is a sudden break even of the pressure and there is a jet which starts. I mean, that is the primary reason why the break happens. So for people who want to, stain the alum a little more by doing staining under air. So what are your tips, sir? I mean, how to prevent that particular situation to happen?
Basically, it was a case of high myop. There was a lot of macular degeneration. You have seen it. So to stain the ILM more precisely, I have injected the dye under air, not under water, to prevent the dilution of the dye. Yes, so when I started my infusion on, just see the video, I have kept my soft tip cannula tip just in front of the infusion cannula to prevent that hydrojet for the break formation. But in this situation, there was already break was present superiorly because of the perivalvular block. That's why the superior detachment happened. So in those situations, you have to keep your patience and do the macular surgery first, then detachment you can tackle. So if you are trying the detachment, not treating your macula, so postoperatively OCT will not show that you have done something. So that is do that.
So instead of being, knowing the tricks of how to start the fluid, but you should still have to be prepared. I think a wonderful bouquet of cases, Dr. Boral. We really enjoyed the presentation. Thank you for making time and being with us here. And thank you very much. I think Piyush, you have sorted out the issue with reference to the video.
I'm here. If Piyush has not sorted out.
Oh, come on. Let me finish so I can start my session in Pune again. Yeah.
Okay, Piyush, you can go ahead. I'll keep Vishal back for some time. So I welcome Piyush back. Please, Piyush, go ahead with your presentation. Let's see if it.
Firstly, Shubhendu sir, there is a reason that you're the king of surgical videos, and my heart was in my mouth when I saw those videos. Absolutely phenomenal management, sir. Let me just quickly. Is it visible, Dr. Thiru?
Yes, visible, Dr. Piyush. You're audible also.
Perfect.
I think before we jinx it.
Okay. So I'll be just showing a few of the older cases that that we have done. And the first one was of an intravitreal pass plane of iron foreign body, where the patient had relatively good vision. There was a clear lens, no retinal tears were noted, and there was a well-healed self-sealed scleral perforation. So if you can manage to localize these intraocular foreign bodies prior to starting surgeries, either with telltale signs as to the localization, and also with the help of imaging, like in this case, we've kind of had an idea it's in the intranasal quadrant. So you can perhaps change your strategy, and what you can see is, you put in your sutures after making scleral flaps, you make partial thickness scleral flaps, try to go as thin as possible. After making the first scleral flap, I'm going to rush through slightly faster. So after you make the first scleral flap, then you do a partial thickness sclerectomy. And after that is done, you gradually keep waiting to be able to trace the foreign body when there is vitreous prolapse. Obviously, you cauterize and try to minimize the chances of any hemorrhage over here. Now you can see that the foreign body is now coming out, and you essentially save up on the entire surgical process of doing a complete vitrectomy in such a situation. So now moving on to the second case, now many times you have these magnetic iron foreign bodies. In case if it's associated with a cataract or the anterior segment is affected, like in this particular case, you after you do a lensectomy or a phaco, or essentially get rid of the cataract, you proceed with vitrectomy. And now many times what happens in these situations, after clearing out the vitreous, like in this situation, you induce PVD, and then you get hold of the foreign body with the intraocular magnet. Now, in this particular case, you were able to pick it up with the forceps and then get it out through the limbal route. This was relatively easier to perform, and we could get the foreign body out. But then many times this is not the case. Intraocular magnets sometimes fail to do the job. That's the irony. So, like in this case, when the magnetic iron foreign body was removed through the pars plana route. Are you able to hear me? Because I'm getting some background noise.
We are able to hear you, Piyush. Please go ahead.
To the pars plana route, especially when you have a clear phakic lens. So what you can see over here is after freeing the foreign body of all its attachments, getting the vitreous out, and enlarging the sclerotomy port, we get a hold of it with the magnet, try to grasp it with the forceps. And it's many times, what you face over here is, all of us have faced this. It tends to keep slipping out and falling back into the vitreous again and again. And so what you see over here is, instead of using the intraocular foreign body magnet again, you use a forceps to pick it up, and then by sort of a handshake technique, kind of just grasp the foreign body with another forceps and try to get it out, as you can see over here. So another similar case wherein again this foreign body kept falling back into the vitreous cavity. You try to pick it up, and earlier it just doesn't. And we have to enlarge. It's a pretty big foreign body, so we have to enlarge the scleral port, and we try to pick it up with the magnet, and it just keeps falling back into the vitreous cavity. Obviously, we can use PFCL or to prevent any inadvertent hydrogenic injury to the macula as well. And finally, we do manage to get the foreign body up, but then getting it out using the magnet itself is extremely difficult. And you can see that even after clearing the vitreous, trying to separate it, but then it just keeps falling back. And finally, we managed to bring it up, and it just goes back again. So finally we get a good grasp with the forceps itself, again not with the magnet, and we are able to deliver the foreign body out. So the number of times that we've started to use intraocular foreign body magnet is going down tremendously. Some of our colleagues, including Dr. Manish Bapai, he has a very nice intraocular foreign body forceps that he has designed to grasp these unusually large foreign bodies as well. So again, this video is also highlighting the same. So if you allow me, I'm just going to skip this. And with this, I've reached the end of the presentation. Thank you.
Okay, I think nice set of cases, Piyush. You did do a lot of justice. So one question is, for the safety of the procedure when you're removing a foreign body, do you believe in that the universal fact that before removing any kind of foreign body from the eye, one should induce a Pvd, or should we retain some vitreous, because if it slips, it's not going to go down and damage the retina?
For sure. I mean, that's always a good idea. In case if it's a smaller foreign body, it's comparatively easier. But then what you saw where was PVD was already induced in some of these cases, and that is why it was a good idea to complete the vitreous removal. Obviously, if you can leave a cushion, it does help significantly.
Okay. Boral, sir? Sir, you're muted, sir.
Sometimes PVD, without induction of PVD, this vitreous gel will help to prevent any macular break formation, number one. Number two, if you are already induced the PVD, you can use the heavy fluid PFCL, but best thing is to use Hilon GV. Hilon GV kind, Hilon or Hilon GV kind of that is viscoelastics.
Viscoelastic, yeah.
Yeah, viscoelastics. These things are really helpful if you are already induced the PVD. But PVD, it is very much protected. After new one of the foreign body, you can induce the PVD.
Yeah. So, Vishal, do you want to comment on this? You're muted again.
No, excellent presentation. Nothing more to add.
So, what is your choice of forceps to pick up metallic foreign bodies, Vishal?
I don't pick up metallic foreign bodies with the forceps. I use a rare earth magnet.
Okay. So what Piyush was showing was that, whenever you use a rare earth magnet and you get up towards the extraction point, majority of the, have you encountered that it gets stuck at the vitreous base sometimes? Or
it gets stuck. So
how do you prevent that without having a forceps?
So the take home message is that first I do, before removing the foreign body, I do a thorough base shaving with indentation from the extraction site, so that the vitreous is clear from there. And sometimes a little uveal tissue prolapse is there, so I trim that with the cutter, and it minimizes the chances of getting stuck into the vitreous base. Still, it does sometimes, but less frequently.
Okay. So, any comments on using something like Macular's diamond dusted forceps?
For what?
for picking up metallic foreign bodies?
No,
because it has a stand blasted. No.
Never done.
Okay.
Sometimes you know what happens is that the magnet is the foreign body is large in size, and the magnetic power is not enough for the rare earth magnet. Sometimes, very rarely. So what I do is I have that big 19th century magnet, the large one also. So I attach it to the distal end of the rare earth magnet. So it gives the extra magnetic power. That is one thing which can be useful very rarely in such scenarios. Otherwise, the rare earth magnet, does its it serves its function properly in every case.
Okay. Bhural sir, any comments on using two magnets, one outside and one probably picking up forceps, which does not allow this thing to fall?
No, please tell me.
Okay. So my question is, majority of the times when we press it, the forceps is going to hold the foreign body.
Yes.
So when the surgeon is picking it up, this is what I have seen. So, I have a problem with the forceps, which, when I activate, it is going to hold onto the foreign body. So the chances of the foreign body falling down is a little more frequent. So we were in RP center, there was a forceps called as the Macular diamond dusted foreign body forceps. There, if you slide it, it is open.
Okay.
The moment you go to the foreign body, you release the slide, it will hold it. So now you need not compress the tip. You just get it up, increase your incision. So you're not actively holding the foreign body. And the second thing that we commonly used to do, or which I do even now, is that I use a larger, stronger magnet at the tip. And when I hold it, this is, holding the foreign body and delivering it out. So this is one thing that I would do. So, sir, any other tips and tricks up your sleeve that you do, sir, in your practice?
No. You can always, handshake technique is the best thing. Anytime, even I am also using the suction of the cutter. Okay? It's not using the magnet, suction of the cutter followed by forceps. If it is forceps is not holding, then it enlarge and use the 20 gauge forceps also. But I have never used this Macular's forceps, whatever you are telling. RP center only.
No, that is correct. It is actually very, very costly. Procuring it is a problem. I'm trying, but I couldn't get one currently. But it was something which really made extraction of foreign bodies very easy. So with those comments, I think we'll welcome the most dynamic VR surgeon from Jaipur, Dr. Vishal Agarwal. He has been a great senior and a very dear colleague, and somebody who answers and says yes, even in scenarios where, if we ask him for help in a day, he is always on the toes to help. Dr. Vishal, please present the video, and we are very excited.
Okay, you can see the screen, and am I audible? Yeah, okay.
Yes, you are audible.
Thank you, Ramlesh, for the kind words, and thank you, KOS and Dr. Ilan, for having me here. It's always a pleasure. This time, although virtually, it's always a pleasure to present in Karnataka. So I've been told to present something about myopic foveoschisis and my experiences about it. So I'll just start with a small introduction. That pathological myopia by definition is refractive error more than -8 diopters. Some literature says -6 diopters, and or axial length of greater than 26.5 mm. And it varies considerably in different geographical regions. But pathological myopia has a high disease burden, and myopic foveoschisis is in literature is reported to be 30 to 40% of patients having more than 8 to 9 diopters of myopia. It results, of course, as we all know, in excessive axial elongation of the eye, which causes the stretching and thinning of the choroid, the RPE, leading to posterior staphyloma, RPE atrophy, lacquer cracks, CNVMs, myopic foveoschisis, and myopic macular hole. So coming to the surgical aspect of myopic foveoschisis, there are a number of problems which have to be addressed. These are not routine surgeries because of the poor contrast and the long length of the eyeball. So the visualization is a problem. The length of the eyeball, induction of the PVD is difficult. And what is the common basic technique which you'll follow to gain reasonable surgical results? So that we are going to discuss. So first, starting with the visualization. So even my take here is that a lot of optical aberrations are there, even if a minimal lenticular opacity is there in these patients as compared to routine VR surgeries. So if you have slightest of lenticular opacities, The patient is more than 40-45 years of age. Do not hesitate. Do either a combined procedure or do a stage procedure. I always prefer to do a phaco-vitrectomy in these cases, and the optical clarity and the quality, increases manifold. As you can see, this is a posterior staphyloma, and the crispness which comes after a phaco IOL, is just at a different level as compared to if you operate under a small amount of lenticular opacity, because you have to be precise. The ILM is thin, there is poor contrast, so you need excellent visualization, and for that a combined procedure is the way to go in these cases. The second point is the length of the eyeball. Now that is the biggest problem, and there are many ways described, and we always follow that you make the ports more superior, around 4.5 to even 5 mm from the limbus, or you remove the cannula to gain more maneuverability to reach the posterior pole. But apart from that, what you can do is, while peeling, so there are two set of myopic fovea. One is where the axial length is more than 30 mm or more than 29.5 mm. These are really long eyes, and here if you use the non-contact wide angle system, your forceps is actually very vertical in these cases, and the shaft of the forceps will touch the rim of the non-contact wide angle systems, and that becomes really troublesome and distorts your view. So in these cases you use the irrigating lens. There is excellent magnification, excellent resolution, and there is no touching of the shaft of the forceps to the viewing system, and it gives you excellent movability of the forceps. As you can see, this was a more than 30 mm eye, and we use the irrigating forceps. You can see the external resolution of the ILM while being peeled, and this is the way to go in these eyes. Of course, if it's around 27 or 28 mm, and then you can do with your routine non-contact wide angle systems. And one trick up your sleeve is, of course, you have to be ambidextrous, and if you are ambidextrous, you can use your other hand also to peel, as my right hand was not reaching here in this long eye, and the left eye is you can see easily approach the posterior pole, and the peeling becomes easy. So you can do that also. Coming to the third point, Pvd induction. So these cases always have a vitroschisis present, as you know, and till you remove that thin layer of cortical vitreous, there is a sure shot chance of recurrence of the hole, the RD, or the fluid. So you have to remove every bit of the cortical vitreous, and these cannot be removed. Seemingly there will be no vitreous, but if you stain again and again, you will find that thin sheet. And this is where we use tricot and create a hole in the hyaloid, and then put PFCL inside that hyaloid. The same technique we have been following in pediatric RD detachments also. So that works very well, and we create a PFCL well in these cases. And once that hole is formed and some amount of PFCL is there, we put more PFCL, and it atraumatically cleaves the hyaloid till the periphery. It's a very reproducible and easy technique once you get knack of it, and it's a sure shot way of removing the last bit of vitreous from the posterior pole at least. But in contrast to the technique I've already described, this should, I think, not be performed in patients again in very high myopic eyes, more than 30 mm of Hg. What happens is these are already long eyes, and if you instill more PFCL, the apparent axial length increases further, and your forceps won't be able to reach to create that hyaloid hole which I just showed you. And in this case, it's better you to use a cutter in a forceps and be patient, and the hyaloid will come off. As you can see, this is a very long eye. I'm injecting tricot, and my forceps is barely reaching the posterior pole, but I'm still managing to grasp some of it, and then I use a cutter to lift up the edge. And a combination of cutter and forceps actually helps me in removing the cortical vitreous sheet. It's a patient job. It takes time, but it's worth it, because without that you won't be able to perform your further maneuvers. So in very long eyes, do not inject PFCL. In moderately long eyes, you can use the technique which I described in the last video using PFCL. And as I showed you, if there is an incomplete removal, this patient had a myopic fovea, developed RD, was operated elsewhere, and when we went inside and did multiple stainings with triamcinolone acetonide and brilliant blue and reti blue, we could see a whole that whole cortical vitreous sheet which I was talking about. and it was, actually causing the whole posterior pole to contract. And there was a mypic macular hole causing that RD. So this sheet was removed and it came in one piece, luckily. And the remaining traction was relieved, ILM peeling was done, and the retina was then bullous and settled, and we injected oil. But having said that, these cases are difficult cases with less than optimal outcomes as compared to the routine cases. And recurrent holes, type 2 closures are very common, recurrent RTs are common. So I just want to describe in the last slide, a common, the lessons we have learned over these years, and a common, basic technique which we have developed, which gives you a good amount of visual function also, and respectable anatomical outcome. So this patient was a 60-year-old female, one-eyed, finger counting close to face was the vision in the right eye. The axial length was 30 mm. The patient was pseudophakic, and the patient had mypic fovea with macular hole with ERM, as you can see. This is just a small animation to tell you what I'm trying to show you here. See, what happens is, I'll just forward it. You make the boards 4.5 to 5 mm. You induce the PVD with multiple steerings using tricot and trypan glue. And in these cases, you don't have to make an additional retinotomy. You just strain the posterior pole with BBG, inject some amount of PFCL, and start doing an inverted ILM flap under the PFCL, as you do in macular hole surgeries also, just under PFCL. The point here being is that the area of the peel should be wide enough so that the retina is redundant enough so that the macular hole is closed. And finally, you aspirate the PFCL, and to you don't have to make a different retinotomy to aspirate the posterior pole fluid. So coming to the video of the same case. So this was a posterior staphyloma, poor contrast to the posterior pole, induced PVD, did multiple staining to ensure that the cortical vitreous layer is removed, and then stain the posterior pole with a combination of blue G and trypan blue. You can see some subretinal dye going inside there, but that's not a cause of worry. You just inject a small amount of PFCL and aspirate that dye, and in that process, the subretinal fluid is also aspirated, so the macula becomes flat, and it's more safer to inject more PFCL. So you enlarge the bubble of the PFCL till the arcades, and now you start peeling. And the peeling has to be in one go, and you cannot peel in bits and pieces, because once you lose the ILM, it's very difficult to catch hold of it again. And the point here again, as I said, is that the angle of the area of the peel should be till the curvature of the staphyloma to make the retina redundant enough, as compared to the other peeling. Here you cannot make a compromise in the area of the peel. It has to be wide angle. And you just stuff the whole ILM as you do it in the routine peelings at the center. Just give a gentle nudge in the center so that it does not dislodge during your future maneuvers. You can see here also that the whole fluid under the pressure of the PFCL has moved to the periphery, but you don't need to drain it because it absorbs by itself by the second day only. Here I'm giving the gentle nudge. I'm going under air now, and you gently aspirate the PFCL, and it's such a stable, reproducible technique that the blue dot here does not dislodge. The flap remains in place, and even after indentation, 360-degree laser, whatever you do, the flap will not dislodge. And you gently aspirate the PFCL, and finally, finally inject C3F8 gas, and the patient did really fine. And these cases have been doing excellently well in long-term follow-ups also. So to conclude, myopic fovea with or without macular hole is a complex surgery with the varied intraoperative surprises. A thorough preoperative workup is a must. Combined procedures, complete Pvd induction, choice of forceps, multiple staining, posterior ports are the key to success. And finally, a thorough preoperative counseling with a very clear communication about the chances of failure, late reopening of holes, redetachments, and modest improvement even in attached retina should be done to the relatives and to the patient. Thank you.
I think that was a brilliant bouquet of cases, Vishal sir. Well done. And do you believe in that fovea should be operated as early as possible, or do you believe in you have to follow them up for quite some time? And if so, what are the pointers that you would want to give us? At what point should one operate a foveal schisis?
So I would not just jump in directly to surgery in patients having a mild vision loss around 612, 618, because these patients, these are difficult surgeries and you can land up in complications. So unless the condition demands surgery, if the patient is incapacitated for vision and does not have navigation vision, and perhaps the patient is one-eyed, I would just do a serial OCTs and check the amount of traction and the fluid, whether it is increasing or decreasing. Sometimes many of these patients have, as you must have seen in your clinic also, are stable over many years and they don't deteriorate and they're okay with their vision. So you don't need to operate in every case.
Yeah. And when you're operating probably a myopic schisis, and probably if you, while operating in, I had this particular thing that I was trying to peel and there was a deroofing and I had a hole. I had a tough time settling that. So I tried doing an inverse peel. It was not possible. So for somebody,
so there are two scenarios. One is if you don't have a hole and you are peeling, then always do a foveal sparing peel. And if you have a hole, then that's not a worry. Then you do a eyelid peeling or a routine peeling, whatever your preferred technique is. But if you have a thinned out retina and it's going to deroof, very likely you do a foveal sparing peel. In all likelihood, it will deroof during your maneuvers.
Okay. Shubhendu sir, any comments on this?
I want to add one thing. Dr. Barbara Padalini has staged the myopic macular hole, myopic macular schisis into like 4 stages, stage 1, 2, 3, 4. Again, they see divided into A, B, C, like partial thick normal, partial thickness macular hole, full thickness macular hole. So I'll ask Dr. Vishal first, like, have you ever used myopic macular buckle? The buckle, macular buckle?
No, sir, I have never used a macular buckle.
No buckle? You have
no experience with the macular buckle.
Basically, there is
for Barbara Parolini and Dr. Pradeep at SN, not many takers for the macular buckle, sir.
I talked to these people and they said that they don't prefer it much. Yeah, so.
Yes, I think none of us from India have ever used macular buckle, I think so. And you were telling, if there is like posterior staphyloma, macular detachment is there, and there is overlying foveal schisis and macular hole. You see, I've seen this whole, this OCT is like this, and there is posterior staphyloma. So you have injected PFCL, sub-PFCL ILM peeling with this inverted flap technique.
Yes.
And the fluid will go to the
periphery.
That scar of fluid will be there just beyond the PFCL.
Yes.
And again, when you are removing the PFCL doing fluid air exchange, have you ever drained the macular hole? Or you are keeping the hole as such that the fluid will again come. You told it will it will be vanished within a couple of weeks. But again, the fluid will come, it will reopen the macular hole even in presence of inverted flap. So what precautions, extra precaution do you take?
So 2 or 3 points. First is that I don't inject PFCL in a very bullous macular detachment. First, as I had shown in my video, I aspirate the subretinal fluid to make the retina flat. Okay. Now that reaccumulation of fluid is not that fast. Even if it is there, it is dislodged by the PFCL to the periphery. So now the second point is, when I remove the PFCL, I do not remove it in a haste. I remove it slowly. So it does not just gush up in the center. And aspirating through the macular hole defeats the whole purpose because it will dislodge my flap, which I very painstakingly stuffed inside the hole. And the third point is, if you do it and leave that fluid, it does not take a couple of weeks. The next day, the fluid will be gone. Unless there is an additional break which you have missed.
Dr. Dinesh Talwar has some comment on this. Basically, if you are just shifting the SRF into periphery, and it is fortunately at the age of posterior staphyloma, you can make some retinotomy there and aspirate the fluid and do the laser.
So that is my whole point. I am telling you that you can always do the retinotomy. That is what I also used to do. But now, if you are sure that there is no other break and you use this technique, there is no requirement of additional retinotomy.
Okay, thank you.
Okay, I think I'll be presenting the last video of the session. Dr. Vishal, is my screen visible?
Yeah, there's a circle with nothing inside it. Is that your screen?
Yeah, that is my screen. So I'll be presenting this particular case. This is a case of trauma which had come to us. So I'll tell you why this was a nightmarish situation. Basically, it was a corneoscleral repair which was done, and somebody said there is a foreign body on the X-ray, and we advised the CT. Patient came back saying that can't really afford it, and after 2 days we had to take him up without the with the non-contrast CT without a 3D reconstruction. We were told that there was a foreign body of about 10 millimeters in size, and this was the situation. He had a membrane in the AC. So in the initial part, I did a peritomy, and because it was recently repaired 3 days back, I put a Suan cannula. The first thing that anybody would probably do is the same, that you manage the AC, remove the membranes. And when I went in, this was a situation that, once I cleared a little bit blood and membranes, there was a foreign body which was sitting in, but it was clearly more than, what was told to me on the CT. And before I tried to attempt it, I looked at all the sides of it. I make sure that, the foreign body was clear of all the membranes on the 4 sides. Then I made a scleral tunnel because I thought that it was more than about 10 millimeters. And then I sutured it so that I could go in and pick it up with the intraocular foreign body forceps. So what I did next was I held it because I had already removed the lens. This extraction would be relatively easy. Then I tried to, get it out. But then I thought that, the incision that I made, which was of about 8 millimeters, was smaller. So I further enlarged it a little more to, kind of accommodate it to the edge of it. So before I let it go, what I did was the uveal tissue which was prolapsing, I took it behind. Then I used a Hoskin to hold with one hand, release the foreign body intraocularly. And then I used the other Hoskin, made some space in the tissue, held the foreign body, and delivered out. So that was the size of the foreign body which is there in the case. Obviously, this particular patient had an end off as well. So the next thing that I probably did was suture the wound and kind of closed, and then went back in to manage to see what was left behind to really, see and manage a particular case. So what I noticed was that majority of the vitreous had these flakes like situation, like a rest kind of a deposition. So this was basically a granite, which was probably very rich in kind of iron, kind of a metal with it. So the patient did have these flake-like things which was there. So within 3 days period, the amount of reaction that the vitreous had was tremendous, and also the patient had a large subretinal bleed which was there in the periphery. But however, after I cleared some amount of membranes here, one could see that the retina is slightly visible, but the overlying vitreous does have these membranes which were very thick. So I did clear as much as possible. I did a good indentation vitrectomy. Then I injected a little PFCL and did clear off all the membranes more onto the periphery. Did a laser. And then with whatever pre-existing breaks were there, I did try to kind of drain whatever little bleed which was coming out, because majority of the blood was clotted this phase of time. And that's the end of the case, and that's the post-operative picture. So foreign bodies, like what Piyush said, can have various size, and this was probably one of a large foreign body situation, and we were not really prepared for this kind of a situation, but it did end well at the end of the day. So if there are any comments, I would want to take them. And Dr. Boral, any comments? I mean, if you want to add something.
How old the history of trauma?
This was, the patient came immediately, sir. He was working in a quarry, there was a blast. And he came to the hospital. They sutured the patient. It came to me, I advised a CT scan. The patient went back and never came back for next 4 days. So this was day 6 picture, sir.
But the evidence of cirrhosis was already setting.
Yes, sir, that's what, I mean, why I presented was for the same reason. That this was a foreign body which we saw, which we intervened immediately also within 5 to 6 days of the presentation of the trauma. The amount, and this was not a metallic foreign body, sir. When I removed it, it was actually granite.
Okay.
It's not a metal piece. It's a granite piece. As the point I wanted to highlight in this particular situation was that the granite which we got out, and when we asked people around, what they said was the content of ferric component in that was so high that in spite of not being metal, but because of the content within the rock itself, that what caused so much of reaction. So I wanted to highlight that part with this particular video. So
It's a nice video.
thank you, sir. Dr. Vishal, any comments? Okay, so with this, I thank all my retina seniors who were part of this colleague. It was really a wonderful experience that you were able to spare the time among such a busy schedule and present so many videos and increase our understanding of the subject. Thank you very much for this, and I hope that this was an entertaining session for the audience as
Hello,
well.
Vanati madam. How are you? You are here for the next session, I
Hello, ma'am.
suppose.
Yes,
Hi, Shubham.
Hello,
the
ma'am.
nightmares in the anterior segment.
Hi, Vishal. Nice to see you all.
Hello, ma'am.
Hi.
Okay. It's RPC
Okay, Dhiru, thank you for the session.
Virtual
Excellent.
RPC alumni.
Yeah.
Virtual.
Really
RPC
nice to
alumni.
see you all.
Yes.
Saujanya, we'll take 5 minutes break before I get a couple of more speakers and then we would start. Is that
Sure,
okay?
doctor, sure.
Sure.
Yeah. I'll just